So dynamic quantity sensory testing is a method that assesses pain processing by measuring an individual's response to multiple stimuli. So multiple stimuli includes cold detection, warm detection, mechanical detection and vibration. So they are using a system called as two-arm parallel group randomized controlled trial. What is two-arm? Which is they use the control as well as the experimental group, and parallel in the sense they give the interventions parallelly throughout the trial duration. And they have injected the lidocaine in the intra-articular. Here I am just talking about a temporomandibular joint where they have used the knee joints. So for the anatomical landmarks for needle entry into the TMJ is like this. We draw an imaginary line from tragus to the outer canthus of the eye, and we measure a few millimeters, and then point the injection there. So the clinical picture is shown here. This is where the needle is placed and the lidocaine is injected. And they have used something called as conditioned pain modulation using cuff elbow measure. So conditioned pain modulation is a physiological phenomenon where the perception of pain to a test stimulus is altered by a second pain stimulus, which is the conditioning stimulus. So here we can see they have given two cuffs in the legs. So the two inflatable cuffs are used, one for the test stimulus and another one for the control stimulus. The test stimulus assesses the pain detection and tolerance thresholds on the dominant leg. So the conditioned stimulus induces a painful pressure stimulus on the contralateral leg. So the CPM effect is the difference in the pain sensitivity measured with and without the control stimulus. They have used a linear mixed effect model. This is the linear mixed effect model, which is nothing but a statistical model that extends linear regression by incorporating both fixed and random effects. Fixed is if there is a stimulus, there is pain. Random is there might be some differences in the effect. So these two are together taken in this linear mixed effect model. And they have used some criteria for assessing their pain. In that they have used early inflammatory arthritis, which refers to a group of inflammatory joint conditions which appears abruptly and causes joint pain, swelling and stiffness. Seropositive RA, which is rheumatoid arthritis with positive antibodies like RF is rheumatoid factor, and ACK is anti-citrullinated protein antibodies. RF antibodies are the target which targets the FC region of the immunoglobulin G. We know the immunoglobulin structure. In that, this targets the FC region. It is associated with extra-articular manifestations and disease severity. Anti-citrullinated protein antibodies are the antibodies that target the proteins that have been modified by citrullination. So when this is the process of where the arginine is replaced by the citrulline. This is the citrullinated antibody protein for which there are antibodies which are produced in rheumatoid arthritis. And they have used seronegative RA also. Psoriatic arthritis, peripheral spondyloarthritis, juvenile idiopathic arthritis, and inflammatory bowel disease associated arthritis. So they have not used only one particular arthritis group, they have used mixed arthritis groups for their analysis. And low non-articular pressure pain threshold, what is that? It is increased sensitivity to pressure pain in areas away from joints, which can indicate central sensitization. We have seen about central sensitization where the pain is from the central area. So they become overly sensitive to pain signals. Pressure pain threshold refers to amount of pressure needed to cause a person to perceive pain. So a low PPT means that pain is felt at a lower pressure than usual, indicating increased sensitivity. So this thing they have used in this. And temporal summation of pain. This is also one criteria they have used in this study. What is temporal summation? You can see there is a stimuli present in one area where the stimulus is given at different intervals of times. Here it is 4 seconds, here it is 1 second, and they form calculating the CAS score. So this is the temporal stimulation, time. Spatial stimulation is the location. We have multiple sensors and they are stimulated at the same time where we can see the VAS scoring. So this is spatial summation and this is temporal summation. And now going to the study. So what is the novelty in this study? So already there are studies on inflammatory arthritis where the study protocol did not incorporate randomization to the placebo or the lidocaine groups. In this study, the authors were able to assess the post-lidocaine injection numerical rating score. I told about the INRS scores along with the pain detect scores. And they took patients who had to fulfill fibromyalgia criteria. Fibromyalgia criteria, I told the WPA and the severity score index. So the aim of the study was the population of patients with the inflammatory arthritis could be stratified into two cohorts based on their response to intra-articular lidocaine injection. So what do we expect in inflammatory arthritis? When there is a lidocaine injection in that particular painful area, the pain has to subside. But there are two groups of people. There are people with the pain getting reduced, and there are people who do not have the reduction in pain. So these are the two cohorts they have used in this study for this article. Materials, the placebo response study. So this trial is the two-armed parallel group randomized controlled trial. The participants were the patients with the inflammatory arthritis, including but not limited to rheumatoid arthritis, as I already mentioned. And they excluded those with underlying joint damage identified on routine X-ray and those under 18 years of age. The randomization was computerized. Randomization was done. The outcomes were they have done the demographics. They assessed the pain scores and they used the saline and the lidocaine for the needle placement. So the sample size, they used the pilot data and found the sample size. And they had another type, the pain phenotypes and their underlying mechanisms in inflammatory arthritis study. Here what they have done, they have selected patients from the previous study. They have selected a particular cohort of patients from a previous study, which is only 40 patients. Here there no randomization was done. And the participants with the diagnosis of inflammatory arthritis were used with particular pain scores. Exclusion criteria mirrored those of randomized controlled trial and excluded the patients who were receiving NSAIDs for arthritis or immunosuppressant therapy. And they also avoided patients using opioids and history of peripheral vascular diseases. So what was the intervention? All patients received intra-articular 1% lidocaine along with the steroid injection. So they added lidocaine and steroid together and standardized amounts as the placebo response study. The outcome was the pain scores they are noted and the quantitative sensory testing was done. They did the temporal summation and as well as the CPM, controlled pain modulation using cuff algometry, and the fibromyalgia status was also determined. So the statistical analysis were done to see what are the effects. The linear mixed effect model was used to estimate the differences between the group and each of the post-intervention time points and adjusted the baseline level of the outcome. So these were the results in the placebo response study. All the diagnosis criteria were all the early inflammatory arthritis till the IBD related arthritis. All these things they have done. And the joints were the knee, wrist, elbow, ankle and the metacarpal joints. So these were the linear mixed effect models which they have done, and this is the pain phenotype model. So finally they concluded that the findings support the concept that post intra-articular lidocaine pain scores could be used to identify the contribution of central versus peripheral processes. The limitations include it was impossible to be certain that lidocaine penetrated all nociceptors at the joint, such as those that are at the subchondral bone. So we don't know whether all the nociceptors were affected by the lidocaine. And although the pain detect questionnaire has been used in the literature to indicate central pain causes, validation against quantitative sensory testing or measures of inferred underlying mechanism inflammatory arthritis is limited, and they did not include participant systemic inflammation process or psychological profiles. And the strengths of the studies, it is an RCT, a direct control group inclusion criteria. The objective pain measurement was used, and then they used diverse pain patient population, which includes most of the inflammatory arthritis group, and they had a balanced baseline characteristics. And synovial fluid analysis was done, which provides an objective marker of joint inflammation. They did the neuropathic pain evaluation, clinical implications. It has a potential for fast, cost-effective pain relief without opioids or steroids. And the standardized pain management approach was can be followed, and minimally invasive treatment was done. So the future scope is they can access long-term efficacy in intra-articular lidocaine. With other treatments we can compare and we can monitor long-term safety and potential, integrate AI models to predict treatment response.